A 20 years old patient, male patient, got admitted to our hospital 2 days back with a severe complaint of fever for the last 2 weeks and chest tightness as well as shortness of breath, some sort of breathness, and which is gradually progressive over the last 15 days. And with this complaint, he got admitted to our hospital. And on admission, we advised some basic investigation like CBC with ESR and chest X-ray. And also, as the patient also present some cervical lymphadenopathy, we also advised him for a peripheral blood film. Now look at this image and successive image also. Sorry, this is actually complete blood count with peripheral blood film. This report shows that hemoglobin is 14, that is normal. ESR quite normal, 0.5 millimeter in first hour. WBC count slightly raised, that is not slightly, it is moderate in amount, 37,450, while the normal range in up to 11,000, and the patient's count is 37 plus 37,450. It is a alarming feature. Okay, and most importantly, in the differential count, the neutrophil 20%, which is less than the lower limit of the normal, and most importantly, the lymphocyte count is 55%. It is at the upper limit of the normal count. Sorry, it is more than the upper limit of the normal count. In adult person, the upper limit of the lymphocyte is 40%, but this patient's lymphocyte count is about 55%. 55% is more than the normal upper limit of the normal. Eosinophil count and monocyte count and basophil, all three are normal. And the last is the atypical cell, where already I marked. The atypical cell is about 20%. You know, in normal person, no atypical should be present in the peripheral blood film. But this patient already have 20% atypical cell, and the total count is 37,000 plus, among which the lymphocyte is predominantly around 55%. So you can guess something wrong just from this differential count. The next panel is RBC panel. In RBC panel, there is nothing abnormality, but the RBC count, okay, quite normal. And most importantly, the hemoglobin count level is normal, 14 gram per deciliter. And here all other parameters on the RBC panel are quite normal. Nothing abnormality there. In the platelet panel, the total count of platelet is grossly reduced, that is 72,000 per cubic millimeter, while the lower limit of the normal range is 1.5 lakh, it should be. But the patient's count is grossly reduced, 72,000. And MPV and other parameters quite normal. Lastly, the most important point in the blood film, that is the peripheral blood film. In peripheral blood film, the RBC is normocytic and normochromic in nature, and WBC increased cellularity with presence of some atypical cell. It is the most important, I think, in this report. The WBC, the comment on WBC is like this: increased cellularity, as because there is 37,000 cellular population of WBC in the patient's blood, peripheral blood. So it is a cellularity of WBC is of course increased with presence of some atypical cells, that is the 20% atypical cell, which is of course an alarming feature. Predominant cell are lymphocyte. Okay, this is all about WBC, and now the platelet is reduced, that is 72,000 only. And finally, the comment: see description, please. Possibility of acute leukemia cannot be ruled out. Possibility of acute leukemia cannot be ruled out. And the pathologist advised the clinician further investigation, including follow flow cytometry for definitive diagnosis. Actually, the clinical and this from this report, we come to the point this could be a case of acute leukemia, most importantly in ALL, that is acute lymphoblastic leukemia. As because the history is very short, just 2 weeks, and patients have sweating, night sweating most importantly, and a low-grade fever. And on examination, patients have lymphadenopathy, cervical lymphadenopathy, and inguinal, very small, but inguinal lymphadenopathy is important. And cervical and axial lymph nodes are already present there. And patients complain abdominal pain, vague abdominal pain. That means, though on clinical examination there is we did not find any periaortic lymph node, but there may be this vague abdominal pain may be due to lymphadenopathy, and we advise him the ultrasonography of the whole abdomen, and the report is pending. Now we will go to the next investigation report. Another important point is on examination, the patients, there are evidence of pleural effusion on the patient's left side. And we draw aspirated the pleural fluid and send, and the report already here. The pleural fluid report, color hemorrhagic, appearance hazy, cell count, that is the WBC count, 1000, sorry, 10,000 is increase. And among the WBC count, 10,000, it is predominantly lymphocyte, 95%, and RBC plenty, that is the hemorrhagic. And biochemistry, that is the protein slightly raised at 3.8. That is, it may be, it may be exudative in NASA. That is, the protein is more than 3 grams, and lymphocyte 95%, mind it. And glucose low, 5 milligram, and no bacteria, and no acid fast bacilli seen. Now the question is, there any malignant cell seen? Okay. This is the final report of pleural fluid study. That is the pleural fluid cytology, no negative for malignant cell. That is, no malignant cell or no atypical cell is seen in the pleural fluid study. Now the final, not final. At this point, this is the last report to show you. That is X-ray test. This is X-ray test of this patient. What is the problem with these chest X-ray? I think it is a very important clinical important X-ray for the student, both undergraduate and postgraduate level. Without knowing the previous slide, without knowing the patient's history, if you go through this X-ray just with this X-ray, what will you say? Take 10 seconds. I'm waiting for your response. Okay. Let me explain this. This is X-ray test peer view. This is X-ray test peer view showing the homogeneous opacity involving the left lung field with obliteration of the costophrenic and cardiophrenic angle on the left side. Trachea shifted to the right side, and the mediastinum also shifted, that is the cardiac shiluti shifted toward the right side. This is all clear to us. Okay. The next point, what is the problem? Okay. Is there any difficulty here? Is there any abnormality here? There is the irregular or lobulated margin from the right paratracheal or hilar region. The margin, the mediastinal margin on the right side is not linear. Rather, it is curved or irregular. That means it is a good X-ray, good case of paratracheal or mediastinal lymphadenopathy. Actually, the lymphadenopathy present on both sides of the trachea. That is the bilateral paratracheal lymphadenopathy. That is mediastinal lymphadenopathy. These features not seen on the left side as because there is pleural effusion and a shifting of the mediastinum to the right side. But on the right side, it is well visualized. That is rounded or lobulated features on the right mediastinal margin or right paratracheal region. Actually, This X-ray shows the left-sided huge pleural effusion. Actually, this X-ray is taken just after the aspiration of about 2 liter pleural fluid. As because patient was on admission was in stress, and clinically it was evident that there is pleural effusion, and without doing X-ray, we insert the white gold needle and draw around 2 liter fluid, and just after that this X-ray was taken. So there is moderate to huge pleural effusion on the left side, mediastinal shifting, and patriarchal lymph node. Actually, this is a definite case of acute leukemia. Most importantly, it may be a case of acute lymphoblastic leukemia, and we're just waiting for the bone marrow study. Today is the